So good afternoon, everyone. Thank you for joining LEJEndo today. My name is Mikey Adamczyk. I'm one of the consultants in St. Peter's Hospital and in CIMIC London. And as always, it's really nice to see everyone for our LEJEndo. So I'm today coming from Valencia. I'm in my wife's childhood bedroom here. It's really hot because all the windows are closed. It's quite loud outside, and we've got some really nice speakers for everyone today. So let me start by introducing the team. We've got Kyle Flesher, who is one of our residents. Kyle is going to be presenting a couple of the small snippets. We've got next Pavle Dmitriev, who is another resident. We've got Benedetta Mondelli, who is a senior resident. And we, of course, got our two guests today who are going to be presenting their paper. And let's start with Diego Raimondo. Diego is a consultant in Bologna. We've known each other probably for about 6 or 7 years, I think, Diego. Now we've met, I think, at the first, I think it was the neuropelviology congress in Zurich. That was a while ago. So thank you very much, Diego, for coming. And we've got Anna Kira Aru, who is a 5th-year resident in Bologna as well, and they're both going to present the paper on stenting, whether to stent or not. So it's a good one, actually. There's always this ongoing debate about stenting. So thank you to Carl Stotz for helping us to continue running those webinars, and thank you for everyone that has joined today, obviously. So Kyle, let's start with you and tell us what we're going to go through today.
Grand. So first of the small snippet paper, I'm presenting this one that was published by a group from 2 different universities in Naples, and the paper highlights that laparoscopic excision of endometrioma and the subsequent techniques have a clearly a depth on the ovarian reserve. They wanted to find how much this was and to what technique was better. So this was a meta-analysis of 10 randomized controlled trials assessing different measures of ovarian reserve. Approaches for hemostasis included barbed and simple sutures, bipolar or ultrasonic energy, and even a hemostatic such as cellulose-derived powders. And this is involved method by calculating the surface area under the cumulative ranking curve area, also known as SUCRA. The authors found that ovarian suturing was ranked technique to avoid reduction of the ovarian reserve. However, some severe bleeding not be managed with suturing only. Or for the use of hemostatic approaches, especially bipolar diathermy. The findings of the paper help surgeons to the best hemostatic approach after endometrioma stripping to preserve the ovarian reserve and avoid damage to the ovaries. So SUCRA is a slightly complex statistics, but essentially what it's trying to do is put all the different studies and data together into one single piece of information that can be analyzed. It summarizes the relative strength and precision of the estimated treatment effects. So looking at this group of graphs, we can see that the barbed and the simple suture performed best relative to the other techniques, so such as bipolar, ultrasound, and the hemostatic matrix. And this was the effect on MH that they've summarized here. This next slide is maybe something we're more comfortable with, which is a forest and box plot of the studies comparing different techniques. Consistently, suturing performed better relative to other forms of hemostatic approaches. And I will take a pause there and hand you over to Pavle.
Just before you go, Pavle, with the previous paper, Carl, did they mention what sort of hemostatic agents did they use? Was it powders? Was it surgery seal? Was it some glues?
It was a combination. They did not specify a single one, but it would have been the powders, the foams, and placement of the kind of the derived things like Surgicel and Fibrillar.
Because I think we need to, I think, have a better, like a deeper look. I at least need to have a deeper look at this paper because it is really interesting. And I'll be very curious to see what actual hemostatic sutures are they, whether using a single stitches, interrupted ones, because that will also take a lot of pressure away from the ovary. So that's quite an interesting paper. And I've seen something recently where some surgeons use glue to stick the ovary together. So that's something interesting to look at as well.
Yeah, I've seen the same, Mikey, actually. It was quite impressive, the glue. Did you see? They were leaving even the ovary bleeding quite a lot. The glue was sealing everything perfectly.
Yeah. Okay, that's one to definitely to have a look for at a later date. Okay, Pablo, you go next.
Great. So I'm going to be presenting a paper about looking at the lower GI function after surgery for deep endometriosis. It's a paper published in July 22 from our colleagues down under in Victoria, Australia. So it's a prospective cohort study comparing GI function before and after the surgery. And they use the ICIQB, which is a shortening for the International Consultation on Incontinence Questionnaire Annual Incontinence Symptoms and Quality of Life module. We're just going to shorten to ICIQB. This survey was done before at 6 weeks, 6 months, and 1 year after surgery, and looking at the pattern, impact on quality of life, and control of bowels that were compared before and after. The findings of the study are listed there, so you can see that the pattern score, impact on quality of life, both had an improvement, whereas bowel control did not. So it was a single center unit, which was comprised of 10 endometriosis surgeons. The recruitment of patients was between 18 and 50 who were planning to undergo laparoscopic surgery based on imaging and clinical findings. All of them underwent imaging prior to surgery, and it was a joint decision between the patient and surgeon, the type of surgery made following an MDT discussion. The mean age of participants was 34. Nearly 50% had a normal BMI, a third were overweight, and the remainder were obese. Nearly 3/4 were nulliparous, and about 13% of patients already had a diagnosis of IBS. And 34 to 41% of participants were actually on hormonal therapy in 12 months following surgery as well. Very briefly about the ICIQB. So it was originally designed to evaluate bowel incontinence symptoms, but its papers have suggested it's a really robust measure of lower GI function. And the questionnaire comprises of 21 elements, 5 of which were used for the bowel pattern, 7 for bowel control, 4 for quality of life, and 4 items weren't used, but they were sort of superfluous. Each item was divided into 2 sections, so whether or not the presence of the symptom was there, grading from 0 to 4, and how much it bothered the patient from 0 to 10. So the higher the score, the worse the function, the more problematic for the patient. So, and at each point, coefficients, so 95% confidence intervals and 2-sided p-values were reported. So the sample size was calculated compared to the functional outcomes after bowel surgery. And they were initially trying to look at the difference between shaving and resection, but it was abandoned due to slow recruitment. So the study is actually only in effect an exploratory study looking at the effects rather than a specific one. For bowel surgery, the unit itself doesn't practice neuropelviology, nerve-sparing surgery, but if nerves were identified, they were left. And if bowel surgery was performed, this was only done if it had been discussed prior to the operation. And they usually recommended bowel surgery for any patient with significant GI symptoms. The 3 types of bowel surgery that they did were either bowel shaving, which was the vast majority, over 80%, or 16% of them had either segmental or disc resection. So the mean bowel lesion site was 2.2 centimeters, and that was recorded in 83% of bowel surgery. And the spread of the deepest layer of involvement is described as above. They deny having any major complications in this study, and the vast majority of patients recovered pretty well post what they report. Now onto the results. So they divide the results into 2 parts. We're mainly going to be looking at the bottom half, so B. The top one is whether or not the pouch of Douglas was obliterated, and the second one is whether or not they had bowel surgery. So out of the 150 roughly people that did have surgery, only 55% had bowel surgery, and so that's the comparison in the bottom half. Where the asterisks are, that you can see on the bottom left, that looks at bowel pattern score, and that significantly has improved at all time points after surgery for patients who underwent bowel surgery, but not for patients without bowel surgery. Likewise, that can be seen in the patients with an obliterated pouch of Douglas. The impact on quality of life significantly improved at 6 weeks for both groups, but only the bowel surgery group at 6 months. So patients who underwent bowel surgery reported lower scores at 6 weeks and 6 months with the question, how much do your bowels interfere with your everyday life? So in summary, the higher the initial scores that were associated, the larger the improvement in scores post-surgery, indicating a benefit from surgery where the initial function is worse. The paper argues that this supports a practice of limiting bowel surgery to cases with severe impact on lower GI function preoperatively. They also feel that the reasoning for this is actually due to the improvement in pain after surgery, the less use of narcotics, reducing constipation, restoration of normal anatomy, and reduction in inflammation. There are, however, I think, quite some significant limitations with the study. So it's a single center study, so not really showing that much variation between surgeons and surgical techniques. And due to the center's move from segmental resection to bowel shaving, they weren't actually able to compare the functional outcomes. They also didn't prospectively collect data on certain outcomes, such as estimated blood loss, operative time, hospital stay, and they argue quite rightly, I think, that more and longer term prospective studies are needed to confirm the findings that they argue for.
Thanks, Pavlo. Pavlo, I've missed it on the beginning. How many colorectal operations have they done?
So they count 149 patients in the study.
This is in how many years?
I think this is over the space of 2 years they look for.
70 per year divided by 10 surgeons. That's okay. So that's around 10 per surgeon. Diego, how many colorectal surgeries do you guys do in Bologna per year? Counting.
Yeah, is like
Colorectal surgery, 2 each Wednesday, so
it's like
8.
No,
8 each
100.
month.
No, 100. We have 3 kids per week.
2, 3.
100 per week per year.
So around 100 every year. And this is counting the segmentals, shaves, and
Segmental.
or is it
Yeah.
on segmentals?
Now we move towards the discoid resection.
Quite a lot, yeah.
And when we have a 3 centimeter nodule on the mid rectum, we prefer to do discoid resection. Yeah.
Okay.
And you?
So we've got for myself, so there's 3 surgeons. I'm at the moment looking probably I've done, I think I'm gonna be around 60 colorectal surgeries by myself this year. And that includes I would say probably 1/3 is going to be discs and segmentals, and the rest are shaves probably. That would be sort of around.
And discoid, when you should discoid resection?
2 centimeters. Yeah,
2
so
centimeters.
less than 2. Yeah, less than
Less
2.
than 2. Okay.
Less than 2. Segmentals, if you've got multiple nodules or high nodules,
Yeah.
usually the same practices as you guys do. Okay, right. This is the paper that we want to hear now. So Diego and Anna, I'll leave it to you to to maybe introduce yourself a little bit. Here, are you presenting this one, or Diego, who is going?
I am going to present this,
So I'm going to make you the host.
Yeah, for the discussion.
Okay, I'm looking forward to it. It's always been a debate about stenting or not stenting. I haven't looked at the paper properly, so I'm really interested to hear what you guys have to say.
Thank you.
So we can share the screen. Okay, so do you see the screen now? Yeah.
You see it properly. Okay. So Thank you for inviting us. It's a pleasure for us to be here. And as you already said, we're going to discuss about the role of preoperative stenting in patients with deep endometriosis and with ureteral involvement. So in particular, we can define ureteral endometriosis as any situation where endometriosis or fibrosis can cause distortion of a normal ureteral anatomy. Actually, the gold standard diagnostic method remained the dissection of the ureter, and so its isolation and inspection of diameter. And the ureteral endometriosis can both be treated with the conservative procedures such as ureterolysis or nodule removal, but also with the radical procedure, mainly consisting in a ureterectomy with an end-to-end anastomosis or ureteroneocystostomy. And we know that surgical procedure can lead to complications such as hydronephrosis, fistula, or need for secondary surgery. So the question is if there are advantages or any benefit to position a stent in the ureter. Theoretical advantages of positioning a stent are the stent can facilitate ureteral identification, guide ureterolysis, prevent ureteral injury, and also help to repair small ureteral lesion. But actually, there is no consensus about the indication of preoperative ureteral stent position in patients with deep endometriosis. The only thing we are sure about is that the main purpose of placing a stent, a double J stent, in a ureter is to recover from obstructive uropathy and to improve renal function. We have already some evidence from literature, such as this article of Ucella and colleagues published on fertility and sterility in 2014. Basically, they show that when there is a moderate or severe hydronephrosis, complication rate is higher. This is due to the fact that when you work on an enlarged ureter, surgery is more complex. So we have in our background, we can consider that when you have a moderate or severe hydronephrosis, you should put a stent, and also in patients affected by endometriosis of the bladder base, because it helps to avoid damaging ureteral ostia. But what we should do when we have just a mild ureteronephrosis, or when there is a large posterior deep endometriosis nodule, so large, we mean more than 3 centimeters. And in these cases, according to literature evidences, we know that there is the risk of ureteral surgery. Well, in these cases, we should balance advantages and downsides. Mainly, ureteral stent positioning can lead to flank pain, risk of urinary infection, risk of excessive surgical dissection, or risk of edema. In a study published by Zilmer and a colleague, they basically compared which were the complications in patient positioning a prophylactic stent and in patient who didn't. And they show that in these cases, in cases with a stent in place, there was a higher risk of urinary fistula and symptomatic hydronephrosis. So with this background, we designed a study, which was an observational single-center retrospective study. We started collecting data in January 2014 and finished in September 2019. We included only patients undergoing a minimal invasive surgery for posterior deep endometriosis with the ureteral involvement. Mainly, inclusion criteria were to have nodule of endometriosis of posterior deep endometriosis larger than 3 centimeters and grade 1 to hydronephrosis. From 2014 to 2016, we systematically placed a stent in the ureter, and so we created the SPS group. From 2016 to 2019, we changed our strategy according to literature evidences, and we stopped to systematically placing stents in the ureter, and so we created the NSPS group. The main outcome was to compare the overall postoperative complication rate between the two groups. When we systematically placed the stent in the ureter, it was placed under cystoscopic guide, under general anesthesia, and before starting the surgical procedure. When in the SPS group, so when a stent was placed only in case of intraoperative need, it was placed always under cystoscopic guide and under laparoscopic control. In the study, we included 202 patients at the beginning, but 18 were excluded because they met exclusion criteria. So in the end, we analyzed data from 184 patients, 88 belonging to the SPS group and 96 to the NSPS group. The two groups were comparable in terms of preoperative variable, except for chronic pelvic pain, dysmenorrhea, and dysuria. They were also comparable in terms of intraoperative variable, except for bilateral ureteral involvement, intra and postoperative stent, and bladder surgery. And at the end, when we analyze the postoperative variables, the two groups were comparable also in this case, but the length of hospital stay was longer in patients who systematically positioned in stent, and also urinary tract infection were more frequent in patients in the SPS group. So we performed a regression logistic analysis, and after adjusting for confounding factors, we found that the adjusted odds ratio in the NSPS group was 0.20. So patients in the NSPS group had a lower risk to get a low tract urinary infection. So in this study, we basically see that according also to other literature evidences, systematically positioning a stent is not associated with a lower risk of complication. It does not reduce specific ureteral complication, but is associated with discomfort to the patient, and it heightens the risk of urinary tract infection. We are aware that the study has some limitation. Basically, it is limited by the fact that it's a single center experience in a tertiary care center, and also the before and after design limits the general visibility of this finding. In fact, we are aware that patients treated during the later period may benefit from an improvement of our experience. There are also some strengths, given that this is to date the first study focusing on the role of preoperative ureteral stenting in patients with large posterior deep endometriosis nodules and grade 1 or 3 hydronephrosis. So in conclusion, we may suggest that patients with deep endometriosis without severe hydronephrosis should be indication to a ureteral stent should be limited, because it is not associated with the significant reduction of major postoperative complication, but it is associated with the higher rate of urinary tract infections. And we thank you for the attention. And this is, as always, the master, as you know.
Yeah.
We are open for discussion.
Brilliant. Thank you very much. That's very interesting, because your summary really sort of, and as I said, just to highlight again, I haven't had a good look at the paper that you guys presented, but the study really sort of shows like with exactly the same thing that we're doing in our unit. So there's a pool outcome that came up. Can everyone see it, or is it only come up for me? Everyone can see it, no? Ureteral extension.
Yeah, we can see it.
Yeah,
it is interesting because the most interviewer, say that I do not. Yeah, I do not. Routine stent for deep endometriosis. Yes, it's according to our study and our policy in our institute. And in your institute, what is the policy?
So we don't routinely stent. So I was, that I've worked really closely with Shaheen, who is actually on holiday today. He's flying at the moment, so he couldn't be here with us today. But I've learned my operating skills and style from him. Mm-hmm. So it's possible. And we don't routinely stent. Okay. We don't routinely stent unless there's hydronephrosis or hydroureter, or unless I'm doing a bladder cystectomy where I'm excising part of the bladder, and in those cases we would put stents in. Routinely we don't do it. The other scenario for stenting would be, in my case, if we're dealing with deep parametria of nodules sort of close to the sacral nerve roots, where the ureter can be pulled to that side. Sometimes, yes, we would ask our urologist to come and put the stents in for us. But in routine practice, at least in our unit, that's not what we do. Is there anything else, Ben, that I'm missing in terms of stenting? I think
no. It's absolutely what we normally do. I wanted to ask you a question, Diego. How do you assess the ureter in your unit after, for example, a very difficult ureterolysis? I see there are some people that use, for example, the ICG. Do you use it? You don't? Do you believe in it?
Yeah. Of course, we published a study, and we use visual glue at white light, so we see the diameter, the caliber, the color of the ureter, and peristalsis, so the motoric. And then we usually use also ICG, so we see with the fluorescence the vascularization of the ureter, around the ureter, so the adventitia. In this case, we can also confirm our visual glue. So this is a second line technique in order to confirm our visual inspection. And according to the degree of vascularization, we can use or not also stent positioning during the intraoperative course. So we ask for urologist and we put the stent in case of devascularization, local devascularization. Yes.
Yeah.
You have you adopted this strategy with ICG for the ureter?
So with ICG, we will start doing them now because we just got our robot approved. So we're getting.
Because I saw a video from you during rectal surgery, and I see that during robotic approach, yes, of course, you use Firefly because I see the Da Vinci robot. So you check the vascularization of the neoanastomosis with ICG.
Yeah.
I believe it is a good tool, is an available tool because all of us has ICG now, maybe not all, but most of us, because we use it for sentinel node technique in metal cancer. So I believe that all of our in the advancing center has ICG. It is a cheap molecular. So if you have the advanced equipment, you can use it in all patients except for patients with allergy to iodine, because this is the only contraindication. Besides the pregnancy, of course. Yeah.
That's correct. Just to maybe plug in, if there's any questions, please put them in the question box on the bottom.
Yeah.
For Diego or for any one of us. Okay, and let's have a look who performs ureteric stenting. So 64 of our participants say that they would get the urology team to stent.
Okay. Yeah.
36 is the by the gynecology team. So interesting, Diego, when we were sort of when in England, when you're doing your training, at least for advanced endometriosis, you kind of need to get signed off for ureteric stenting to complete it. Now I got signed off for it, but I must say that I don't feel comfortable stenting myself. I always get the urologist. Maybe because I don't do them that often. I guess if I had to do them on all cases, I'll be more comfortable. And do you guys get the urologist to help you with it, or you do it yourself?
Yeah. We ask for urologists. Yeah. We have a multidisciplinary surgical team, so we meet before the surgery, the urologist, and then we plan for their presence in our like in UK, I believe. Because we know that there are some factors associated to the presence of ureteral involvement, so we use them to plan surgery with our urologist. Yeah.
Okay, great. Okay, there's no other questions at the moment. Kyle, do you guys want to go with your last two summaries?
Yeah, sounds good. So everyone seeing everything okay?
Yeah.
Okay, Pavle, we've got your presentation of this nice review.
Oh, great, fine. So this is a study looking at the benefits of physical therapy in quality of life and pain associated with endometriosis, systematic and review and meta-analysis. And The paper claims that it appears to be the first one actually looking at the effectiveness of non-invasive, non-pharmacologic conservative therapies in doing so. There were 7 databases that were used for looking through, and the studies from inception to March 22 were researched. The eligibility criteria were women who had endometriosis diagnosed either by golden standard laparoscopy and histology or via imaging. The intervention was either manual therapy, electrotherapy, therapeutic exercise, patient education, and physiotherapy. Comparisons were placebo and control, and outcome was pain intensity and quality of life. There were certain exclusion criteria, such as pregnant patients, trials conducted on non-human models, such as TABAs, and alternative therapies, such as acupuncture. Using all of this was whittled down to only 6 papers being identified that could be used in this systematic review. They used the physiotherapy evidence database scale, so the PEDRO scale, which is the image on the left, to look at the internal validity of the randomized control trials that they were looking at. So the PEDRO scale is actually 11 items and gives scoring from 1 to 10. 1 of these is not used, so the maximum is 10 points, and 3 showed a fair quality and 3 showing good quality, so scores of 7 or greater. The Cochrane risk of bias tool looked at the potential bias and internal validity of the studies and classified them as low, unclear, or high risk, and most of these were low risk based on 7 criteria. So the 6 randomized control trials included 391 women with endometriosis ranging from the ages of 15 to 50, and each study varied between the minimum of 34 to 101 participants. The duration of symptoms for patients ranged for 14 to 12 weeks before the diagnosis of endometriosis. And given the nature of the papers, there's actually a lot of variability in the therapies that were offered to the patients. So 2 of the studies used electrotherapy, applied therapy to exercise. 1 was manual therapy, and 1 was self-care counseling. Also, the frequency and duration of the interventions were really heterogeneous across all studies. So electrotherapy was up to 56 sessions lasting 40 minutes at a time. Exercise sessions were up to 24, lasting up to 2 hours. Manual therapy was 5 sessions, 30 minutes, and self-care was 90 minutes, 7 sessions. The interventions as well, sorry, just on the previous slide. So the outcome measures that they basically use were pain and quality of life. They used 2 studies used the visual analog scale, 1 used the numerical rating scale, and 1 used the present pain intensity scale. 3 different forms were used for quality of life, and I won't go into that because it's a bit too much to read at the moment. The findings of the meta-analysis showed that physiotherapy interventions improved pain intensity in patients with endometriosis compared to placebo, but that the quality of life, which was measured in 5 of the 6 studies after intervention, the quantitative analysis showed that the conservative approach did not improve overall life quality, but that it did improve physical function subcategories when in regards to quality of life. There was no improvement in social function or emotional function either from conservative therapies. So in summary, we know, well, the paper finds that the non-invasive treatments did improve pain intensity and physical function, and previous studies have investigated that pelvic floor dysfunction is pretty high in women with deep endometriosis, and so the study feels that the pain intensity could have been decreased because of the effects of physical therapy on pelvic floor muscles, which is sort of in keeping with previous studies. The study does, however, have several limitations. First of all, it's a really small number of studies that were included, only 6, and the treatments that were used to improve pain were really heterogeneous, not only in terms of what treatments were offered, but also the frequency and duration of those treatments. Finally, the sample sizes were also really small in each of the studies, with a maximum of just over 100. They also don't discuss in the paper whether they feel that the diagnosis of endometriosis without golden standard of diagnosis sort of validates the papers that they're looking for. finally, I think it would be interesting, even though this has been a randomized control study, is that they don't mention whether or not there's been any studies that they've looked at or that they're excluding that looked at the benefits of co-joint therapy between surgery and physical therapy, looking at long-term improvement of pain.
Great.
So Diego, I know you've published quite a lot on central sensitization, pelvic floor function, and even chronic constipation with regards to people living with endometriosis. Do you have any thoughts about this paper with regards to that? Is there anything you found within your research which relates to physical therapy in a positive sense?
Yeah, of course, yeah, because the patient with endometriosis have an high rate of nociceptive pain and a high rate of nociplastic pain. It is a pain that originates from the unaltered organization and processing of the pain stimuli in the brain. So of course, if you have a CSS, so a central sensitization syndrome, you have a problem with this type of processing of the pain. And usually patient with this type of syndrome has multiple dysfunction also at the level of the pelvic floor level. And so we have a high number of patients with pelvic floor dysfunction. And we studied a lot this aspect because with transperineal ultrasound we can evaluate the strength of the muscle, also the capacity of the muscle to have relaxation. And most of the patients with endometriosis, most of the patients with deep endometriosis has a dysfunction of this muscle. And this is one of the key points of the syndrome, of the central sensitization syndrome. So we don't have only the lesion, we don't have only pain in the abdomen, cyclic or not cyclic. We have also a corollarium of symptoms that generate the complaints of the patient. So we have to work on different levels to have a better control of pain and in order to have an improvement of the quality of life of this ladies. Yeah.
Mm-hmm. This is really interesting, Diego, because we also see a lot of patients with chronic pain that for one reason or another, maybe the pain is not completely gone or improved with surgery, and I strongly believe in rehabilitation, in physiotherapy, and all the other non-surgical or post-surgical treatments for those patients. So I'm 100% with it. And I've always...
It is difficult because you have to work with different specialists and you have to improve with them. So at the beginning, it's not easy to explain to other specialists the endometriosis and this complex disease, because you can have an involvement of all the organs in the pelvis and also in the abdomen. So at the beginning, you have some trouble because the disease is complex. It's not an usual disease for physiotherapists, but after weeks after weeks, yeah, you can have a very good improvement of the teamwork and also of the clinical outcome of the ladies. Maybe also Anna can say something about this aspect. Do you notice some good clinical outcomes after this?
Yeah, actually, yes, patients respond greatly, I think, to physical therapy. In our experience, we see that the multidisciplinary approach is the one who pays better. So yeah, in terms of improvement of pain and quality of life, they really get better when they also, it's like a way of taking care of themselves. And so they respond better, also physically and psychologically.
I 100% agree. I 100% agree. And I'm gonna tell you guys, every year when I come to Valencia, I always have a beer with my brother-in-law, and we always there's always at least a couple of conversations about pain, and I've been trying to convince him for the past few years to look into deep brain stimulation for chronic pelvic pain, because that's his background. He does all the Parkinson's neurostimulation in Barcelona, and they were very close of starting a trial actually last year for endometriosis for patients.
Yeah. It's a very good idea. I believe that it could be a good topic to explore. Yeah. Because if you have a questionnaire like a CSI questionnaire that we use in JMIG article, yeah, you can select the lady, then you can choose this questionnaire to select the target patient. Of course, this is a good option to treat central pain. Yeah. Because of course we have some pharmacological drugs, but in young women, these drugs has several side effects that limits their life, because yes, of course they are young women, so they have a good enough involvement in life tasks. So some drug that decelerate them can create some problems. Yeah.
Okay, just a couple of questions, Diego, for you guys. Avril, who's one of our other fellows, Avril Baki, is asking, how long would you recommend physiotherapy for?
Yeah, this is a debate because we have no data about it. In the study from Simone del Forno, we use a 4-week period, but our clinical activity suggests us to use it for at least 3 months to have a good improvement of sexual activity, at least, and then you can repeat if you have some stress factors.
And there's one more question from Melis Kantor. Thank you for this great seminar. Can we relate persistence of pain to central sensitization after surgery, or is this a sign of unsuccessful surgery?
Yeah, I believe this is an independent. There are independent factors, because we know that a good surgery, I believe we can summarize that a good surgery is I remove the lesion and I don't create alteration or complication of the pelvic organs. And of course, the pain control, it is good after a complete surgery, but it's not an automatic response, because we can have persistence if we have a central component, an angioplastic pain, and we have to use other pain technique, other technique to reduce the pain, like physical therapy, of course, or a specialist of pain, so anesthesiologist and stuff like this. So I don't think that a bad surgery can create central sensitization syndrome, because yes, of course, a good surgery can relieve symptoms, but not in all patients. So it is difficult to have a good response. What is your idea?
No, actually, I think the same. To manage pain in patients with endometriosis is a great problem, because of course, the fact that sometimes the pain is not just under an organic cause, but there are more complex roots and central sensitization, but also like rearrangement of nerves, growth factor in the pelvis, new born of nerve fibers, disorganization, and so on. And so sometimes the patients respond well, but we don't know why. And sometimes when they do not respond, they also do not know and maybe because it's more complex than we think.
Yeah, I believe that this question has only one response. Good surgery cannot provide in all cases a good control of pain, and this is an idea that we have to bear in mind when we have to cancel the patient before surgery.
Yeah, I think I would agree with you guys on that one. I do. There's one more question from Alice. Samtruk, do you always prescribe suppressive therapy after surgery to control pain and recovery?
Yeah, of course, we prescribe hormonal therapy, progestin therapy most of the time, and we use a long-term therapy. And as you know, this is the only way to reduce the risk of recurrence of symptoms, the risk of recurrence of lesion. So we strongly believe that is a good strategy to stop menses and to have progestin therapy after surgery for a long period until the patient will seek pregnancy or will have menopausal status. Yeah.
Okay.
There are also some papers that say that suppressive therapy reduces the risk, for example, recurrence of endometriomas as well. I wanted to ask you, Diego, one last question from me. In your unit in Bologna, do you have a dedicated specialist such as dietitians, physiotherapy that have a knowledge about endometriosis, that are going to be always the same one looking after your patients, or not really?
Yeah, we have a team now of physiotherapists, and of course they have initial experience with us from the last year.
Yes.
Yeah. Before we have only one physiotherapist. Now we have a team, and yes, of course they learn how to manage this disease, and according to their experience, it is a complex disease because we have a lot of things to manage, because it is not only pelvic floor, but also how the patient birth, the abdominal muscle. So we have to reconstruct the mobility of the lady also.
And we also have a psychologist specialized in sexuality.
Yeah. And the combination of physical therapy and psychological therapy is essential, because complex disease like deep endometriosis, but not only, also women with adenomyosis or ovarian endometriosis can have central sensation syndrome. So we have to pay attention, because it's not only a complex multivisual disease to have this type of situation, but also young women with adenomyosis or also adenomyosis, endometriosis of the ovaries can have this, and a combination of a specialist can have can be a good point to start our work on them and to improve their clinical outcomes.
Yeah.
Okay. I think we've got one more back, Kyle. Is that right?
Yeah, one more to go. I'm going to launch a poll, but I think we'll need to get Diego and his team back to talk about his central sensitization paper. That was from JMIG in the last year, wasn't it, Diego?
Mm-hmm.
Yeah, we'll definitely need you back. So I'm going to launch a poll now, and we'll put the results at the end. But I'm going to be talking about this paper that was published by a group from Beijing. And this study devises a refined classification system for adenomyosis using MRI. So this is a retrospective cohort study that includes 468 patients diagnosed with adenomyosis through MRI at Peking University Third Hospital from January 15 to October 2020. The patients were categorized into 4 subtypes based on MRI, and the background to this paper being that symptoms of adenomyosis can vary significantly, some being more affected by pain, whereas others being more affected by abnormal uterine bleeding, and there is no universally accepted classification system. So info such as age, dysmenorrhea, menorrhagia, infertility, ART, and drug treatments and its efficacy were analysed. And this analysis was performed to determine the significance of the differences observed between the different subtypes. Patients with gynecological malignancy, menopause, pregnancy, and uterine fibroids more than 5 centimeters, as well as uterine malformations, were excluded. 2 experienced radiologists reviewed the results and selected the 468 patients with typical lesions that could be clearly and uniformly classified. The study compared the clinical information of different subtypes to provide better fertility guidance and find better treatment strategies for these patients. This study highlighted the differences in age, dysmenorrhea, menorrhagia, and infertility among patients with different subtypes that they had defined. And this can be helpful in developing personalized treatments for these patients. So this is the classification system that they used. And the 4 subtypes are as follows. So in intrinsic, the lesions were mainly located in the internal myometrium, accompanied by a thickened junctional zone and an intact serosa. And normal muscular structures were preserved between the lesions and the serosa. Subtype 2, the lesions were mainly located in the external myometrium, accompanied by an involved serosa with an intact junctional zone. And normal muscular structures were preserved between the lesions and the junctional zone. Subtype 3, intramural, lesions were located independently in the middle of the myometrium without any relationship to the junctional zone or the serosa. And then subtype 4, which maybe previously has been described as diffuse or undefined, was described as penetrating. And these lesions involve both serosa and the junctional zone. So these are typical MRI images of the different subtypes. As you can see, A is intrinsic, where the serosa is unaffected, but the internal myometrium and the junctional zone is. B is extrinsic, C intramural, and then D on the bottom right, penetrating. So here are their tabulated results with significant differences in age, dysmenorrhea, menorrhagia, and infertility between the different subtypes. The proportion of dysmenorrhea increased in intrinsic, extrinsic, intramural, and penetrating subtypes. The proportion of menorrhagia was significantly higher in the intrinsic subtype compared to the extrinsic and intramural subtype. And interestingly, there was an increased correlation between deep endometriosis and endometrioma with the extrinsic and penetrating disease. This table highlights the different responses to hormonal therapy, and those with the intrinsic disease were less likely to respond to progesterone. And for the purposes of this paper, progesterone denotes the cumulative data for all the other treatments. So intrauterine system, progesterone-only pill, and Dynagest. And finally, here is the slide representing the fertility data, the left showing the proportions of primary and secondary infertility according to the subtype, and then on the right, the response to assisted reproductive techniques. The infertility rates of adenomyosis patients with different subtypes was relatively high and was highest of the extrinsic subtype overall. So study found significant differences in clinical symptoms and therapeutic strategies for different subtypes of adenomyosis. The study suggests that further data is required. It provides an insight into the heterogeneity of clinical symptoms and therefore potential therapeutic strategies for each subtype. It is important to note, however, that this was a single center study, which may limit the generalizability of the findings to other populations. Another limitation, I think, here is the use of clear to define cases. So as we mentioned before, 2 radiologists determined which patients to select, which obviously increases the aspects of selection bias. And finally, the study only analyzed the clinical information that was described and did not consider other potential factors that may affect the therapeutic efficacy of different subtypes of adenomyosis.
Thanks, Kyle. Thank you. Great presentation as always from you. Diego, what do you guys use for? Okay, we've got our poll coming back. So most people don't actually. Okay, I use ultrasound-based systems. So there's a lot of Musa classification users.
Yeah, we use MUSA according to MUSA criteria. We adopt ultrasound, not MRI, to diagnose adenomyosis, and we use two direct criteria, one not direct criteria to diagnose adenomyosis, especially in a young woman, which we don't have a huge uterus with all the features that we can have.
And do you have HIFU available to you?
Do you have it?
What?
HIFU. Treatment.
No. We don't have this technology. We don't have experience with it. And yes, I read something about. I believe that is a good option to manage adenomyosis. And maybe do you have it?
We don't have it now. There's, I think, one place in England, as far as I know, that offers it, but we don't routinely.
Yeah.
Quite limited in what we can do with adenomyosis, to be fair.
Yeah, I read it has promising data, but of course we don't have now, so we have to explore it after.
And in terms of surgical options, Diego, do you perform adenomyomectomies? Do you do that?
Yeah, we perform adenomyomectomy, but we don't have to use surgery for adenomyosis patients. Yeah, we used to manage them only in selected cases. Yeah, we used to treat this lady with hormonal therapy and wait and see strategy. Only in patients suffering of infertility and seeking pregnancy. Of course, we can manage it, but we think that this type of surgery has not a good balance between benefits and risks. So we use it in very few occasions. Yeah.
On the other side, we use, in case of adenomyosis, a lot of intrauterine systems.
Yeah. To control for
when they do not
for pain and abdominal bleeding. Yeah, of course we use intrauterine system releasing progesterone, but in case of big adenomyoma and patient with infertility, in some cases we use to do surgery, but we cancel a lot the patient and we decide for surgery after in a very selected patient, because we know that we can have some problem after during pregnancy, and not in all cases we can have pregnancy after our surgery. So it is a matter of debate. And you, do you prefer to use adenomyomectomy?
We you know what, we don't offer it to our patients. I think it's very debatable. I don't have much experience with adenomyomectomies myself, and that's what I tell my patients. On the other hand, I also understand that we really want to leave behind a healthy organ that is capable of carrying a pregnancy by the end of the day.
Yeah, but because the big problem is that if you have a focal adenomyosis or a real adenomyoma, the surrounding uterus is involved by adenomyosis. And always in most of the cases. So at the end, you don't have a good healthy myometrium to have surgery to have a normal deliveries after. So yeah, you select the correct patient, and it is difficult to the selection, and so we restrict it to very few cases. Yeah.
The selection is very difficult. High chances of uterine rupture. I think the quotes from Japan are at the level, which is very high. You need to excise all the adenomyosis to have healthy tissue being close together, which is difficult. And I think from memory, it has to be less than 30%. Otherwise, you won't have enough tissue to close it. but I personally don't have experience with adenomyomectomies. I don't know actually many people well, at least that I work with, that do. I think most of adenomyomectomies are done in Asia. But yeah, it's definitely something. I've got a lot of patients asking about it, but I'm just honest, tell them that I don't have experience with it. So I'll be sending them to you, Diego, okay?
Okay.
Okay, I think we're gonna close now. It's 7 o'clock, 8 o'clock over here. I'm about to go jump in a pool because it's really, really hot here in Valencia. Thank you very much, everyone, for joining us. Thank you, Diego. Thank you, Adam, Ben, Pavlo.
Thank you, everyone.
Thank you.
To have you in this journal. It was a very good experience, I believe, also for
Yes, yes.
Yeah, we very
Thank you.
Like this type of format, and maybe we can replicate it in Bologna after. So
All right.
we invite you all in Bologna to have this type of format, because I believe it is again a good option to share experience.
Yeah, in a friendly way.
Yeah, in a friendly way. Yeah, absolutely. Yeah. This is the most important thing.
Okay.
So, bye.
Bye-bye.
Bye,
Thank you.
everyone.
Thanks so much.
Thank you.